morning. I am Dr. Gajendra Dubey. I am Professor of Cardiology at UNMICRC Institute of Cardiology and Research Center, Ahmedabad. Today I will be talking about below the knee interventions for peripheral arterial disease. So below the knee interventions are typically performed for critical limb ischemia. So critical limb ischemia is a clinical condition where the blood flow to extremities is reduced to such an extent that it leads to ischemic rest pain or minor tissue loss or major tissue loss. So there are several classifications to grade this critical limb ischemia. So the most widely used classification is the Rutherford classification. So in this classification, grade 2 and 3 constitute critical limb ischemia, and it includes category 4, 5 and 6, which includes ischemic rest pain, minor tissue loss or major tissue loss. Similarly, there is another widely used classification, that is Fontaine classification. In this classification, stage 3 and 4, that is nocturnal pain or rest pain or tissue loss with ischemic ulcers or gangrene, are classified as critical limb ischemia. It can be both acute or chronic, and the risk factors for critical limb ischemia are similar to those for atherosclerotic coronary artery disease, and most common or most prevalent of them is smoking, followed by diabetes, hypertension, dyslipidemia and aging also. So these are the various risk factors, and these are the classifications for critical limb ischemia. So regarding BTK interventions, what are the indications for BTK interventions? So BTK interventions are recommended for pain control. Say patient, someone who is having persistent ischemic rest pain, they should undergo BTK interventions. For management of ulcers and gangrenes, this should be combined with treatment of ulcer, which includes infection control and local treatment plus pressure relief. For salvaging limb and limiting the extent of amputation. So these three are the major indications. The most prominent of them is the limb salvage. So while doing BTK intervention, we should, or the operator should, attempt to establish a straight inline flow to the affected area to get a good result or good healing and prevent amputation. Both good inflow, that is from iotoiliac and common femoral or SFA, and outflow, that is distal to the occluded segment. So these two areas should have good flow so that one can get a good result or a durable result. So BTK interventions only for claudication are not indicated, and they have never been shown to be beneficial. And another important thing is that long-term patency of BTK vessels is not obligatory for clinical improvement. So even if we are able to keep them open for a few months, it leads to ulcer healing and potential limb salvage. And even if the vessel occludes after a few months, the clinical improvement is persistent. So we should try to open it up and give a good result initially, but it is not a must that it should be patent for years altogether to get a good result clinically. So looking at endovascular treatment of CLI, it is a complex problem. Mostly CLI happens when there is a frequent involvement of multiple segments and the blood supply to foot is markedly decreased. The typical scenario consists of treatment of more than one vascular beds, which can include either iotoiliac, common femoral, SFA, popliteal and below knee vessels. And it needs application of multiple tools and technologies and collaboration between interventionists, the vascular surgeon and the plastic surgeon, and also someone who is expert in, say, management of foot ulcers. And the outcomes of all these patients are related to multiple anatomic and physiological parameters. These patients who present with CLI frequently have other coexisting diseases like coronary artery disease, left ventricular dysfunction, old age. So the overall outcome will depend on other factors also. So if we look at the segments which are involved in patients who present with CLI, so almost 5% of patients have multi-level disease, which involves all the segments extending from iotoiliac to below knee segment. Around 3% patients with only iotoiliac disease can present with CLI. Around 1% of patients have iotoiliac plus femoral disease. And around 4% of patients have only femoral disease and present with CLI. And almost 30% patients have infrainguinal disease in form of either femoral plus popliteal and tibial disease. And almost the majority of patients have generally popliteal or below knee disease, which includes tibial vessels also. So this today's talk will be focused on mostly this last segment, which is most common, that is popliteal and tibial disease, which is most frequently responsible for CLI. So if we come at the endovascular strategy, So as I earlier discussed that to the extent possible we should treat all the lesions to obtain a good inline flow to the affected area. And choice of tibial revascularization, that is whether to go for the anterior tibial or posterior tibial, it depends on patient's anatomy and symptoms. The imaging of peripheral vasculature prior to the intervention is of utmost importance. Imaging can be done either with a CT angiogram or MR angiogram in patients who have some issues with renal dysfunction, and DSAs are generally reserved for intervention. So good imaging, preferably non-invasive like CT angio or MR angio, are very important for planning and execution of BTK interventions. They give us an idea about the extent of disease, the vessel to be targeted, the access which we can take, and both inflow and outflow also. So this is a must before taking up a patient for BTK intervention. So this is the diagram which shows various angiosomes. The angiosome concept is basically to revascularize the vessel which is supplying the affected area, that is the area which is having the ulcer. So the diagram on left hand side is of the dorsal aspect of feet, and the diagram on right hand side is of the plantar aspect of feet. So as we can see on the dorsal aspect, the predominant supply is via the anterior tibial and dorsalis pedis artery, with a small area laterally supplied by the lateral plantar branch of the posterior tibial artery, and a small area near the ankle joint is supplied by the peroneal artery. So dorsum of the foot is predominantly supplied by the anterior tibial and dorsalis pedis, and if you look at the plantar aspect, the main supply is from the posterior tibial. It has two terminal branches, the lateral plantar artery and the medial plantar artery. The lateral plantar artery supplies the lateral 2/3 of the feet, while the medial plantar artery supplies the medial 1/3. And small areas are supplied near the heel are supplied by the peroneal artery. So we should try to target the culprit vessel, but it may not be possible all the times because the culprit vessel may not have a good distal runoff. So in that scenario, we should try to revascularize at least one vessel which is going to the foot and has a good outflow, so that it can give collaterals and may be useful in healing of the wound. So if we come to the toolbox, the access can be either antegrade access in the common femoral or superficial femoral artery, crossover access using the contralateral femoral, or a retrograde access from the pedal arteries. And support catheters are very important. Support catheters are as important as microcatheters are in CTO intervention. So they can be O35, O18 or O14 compatible depending upon the vessel which we are going to revascularize and the wires which we are using. And we should have at least a decent variety of wires which should include both workhorse and specialty wires to revascularize the tibial vessels. And plus there are dedicated long balloons which come in small diameters, say starting from 2.5 to 3 or 4 millimeter and lengths of 100 to 200 millimeters. These long balloons are very important for ballooning the tibial vessels. And plus nowadays we have drug-eluting balloons also for BTK vessels, and cutting balloons can be used in heavily calcified blockages. Other adjunctive techniques include atherectomy, stents and thrombectomy devices, and they can be useful in helping us getting a good result. So if we come to the access, the antegrade access has several advantages. It gives us a good pushability and support, but it needs a healthy CFA and proximal SFA so that we can puncture that area and put in a sheath there. And USG and fluoro guidance should be used to get an antegrade access, otherwise it is associated with higher rates of complications, predominantly hematoma, bleeding and even AV fistulas also. And antegrade access is much more preferable in taller patients, because in tall patients the crossover access may be associated with inadequate length of our balloons and other hardware, and the pushability is not that great with crossover access, so while it is very good with antegrade access. So retrograde CFA crossover access can be used in smaller patients, and it depends on the body habitus of patient and status of the SFA and common femoral arteries. It gives us the advantage of ability to revascularize multiple segments from CIA, external iliac, femoral, SFA and below-knee vessels also, but it compromises the pushability and support that is obtained with antegrade access. So pedal access is used when we are not able to recanalize the vessel via the antegrade approach. So ultrasound should always be used to obtain a pedal access, and a vessel which is good caliber and has good distal flow, that should be selected for pedal access. It can be either anterior tibial or posterior tibial or high dorsalis pedis. Peroneal is generally not preferable, but people do take peroneal artery also in case they are not able to get anterior tibial or posterior tibial. And the entry point should be close to the ankle so that it can be compressed, and the vessel size is relatively smaller. So one should try to either go sheathless, that is just put in a small microcatheter and wire, or if required a sheath, that is dedicated pedal sheaths are available, they can be used for pedal access. The main concern with pedal access is that putting in a sheath or a bulkier device there can lead to dissection or spasm and closing of the vessel, and it can lead to deterioration of patient's symptoms and critical limb ischemia. And the fourth access or the fourth alternative route is either pedal loop or transcollateral pathway. The pedal loop just consists of like going through dorsalis pedis and the plantar arch to the posterior tibial, or the other way around. It can be used as the last alternative when nothing is working, but it may not always be possible. So this is an ultrasound image of the dorsalis pedis. All the interventionists who are performing BTK interventions, they should be well versed with Doppler and ultrasound imaging of lower limb vessels, so that because it is pivotal to BTK interventions and to get distal accesses. Without that, it is very difficult. So if we come to access again, the tip of sheath or guide catheter should be kept as close to the knee as possible. It improves pushability, it decreases the contrast media, and it gives very good image quality, and it makes wire or catheter exchanges much easier or faster. So here we can see the sheath tip is just at the knee joint, and we can get very good images with minimum amount of contrast. So support catheters have already discussed. There are multiple support catheters available, like the Trailblazer from Medtronic, or Navicross from Termo, or Cook-CXI, and other vendors are also have come up with multiple support catheters. So support catheters, balloons can also be used as support catheters, but preferable are support catheters, because balloons don't give you that freedom of movement of wire which is present in good support catheter. They are useful, they increase the support to wire and increase their tip load and help us in crossing complex lesions. They are also useful, that is after crossing a lesion, one can change the CTO wire to a workhorse wire, and they give us good trackability, torque control, and pushability as well as visibility. So they are a must for BTK interventions. And the third and most important component is the wires. So they are critical to success. If we are treating the popliteal artery, one can go ahead with a 035, 018 or 014 wire, and one should try to obtain a true lumen passage instead of dissection re-entry, because re-entry opportunities are limited in popliteal artery, plus stenting popliteal artery which runs across a joint is not a great idea. So if possible, one should try to remain intraluminal, so that we can get a good result with a plain balloon followed by a drug-eluting balloon. So if we come to the tibial vessels, 035 wires are not preferred, because if they loop around, they are likely to damage the vessel and can lead to perforation. So one should preferably use a 014 wire, and most of the hardwares like balloons or atherectomy devices or stents, they are 014 compatible. So that is also one reason to use 014 wires. Plus they are much more safer and more useful or effective in crossing occluded tibial vessel as compared to 035 wires. 018 wires can also be used in case the lesion or occlusion is very hard, or it is not, one is not able to penetrate the lesion with a 014 wire. So the wires can be divided into either workhorse wires, which include wires like the Spartacore wire. They have low tip load but good support, so they are useful for putting in balloons or stents once the lesion has been crossed. And for crossing, one can use either polymer coated wires like the Commando 014 extra support or 018 extra support wire. These are very good wires with medium tip load, and they have very good crossability. Similarly, there is V14 and V18 wire, and the next category is stiff CTO wires like a Stato 20 or 40, or Hornet wire, which is used in coronaries like Hornet 10 and 14, or Confianza Pro 9 and 12 can also be used for BTK CTOs. So these are few case examples where we can see that this is a complex calcified BTK disease involving the anterior tibial and tibioperoneal trunk. So here you need a good tip wire, which is preferably hydrophilic, which has good torque control and good support. So these are few examples of CTOs which have been crossed with various wires. The loops and dissection re-entry or subintimal entry starring can also be used in case of long calcified occlusions and if intraluminal passage is not possible, and polymer coated wires are better suited for that. So this is another example of use of a support catheter for treating a BTK vessel, BTK disease, and this was followed by a ballooning with a long balloon, and there was a good result with good distal runoff into the foot. So various balloons are available for BTK interventions, both over the wire as well as monorail balloons are available for these. So over the wire balloons are more preferable because they give us a better trackability and better pushability, and the wire can be exchanged and they can be used as support catheters also. And the advantage with monorail balloon is that they can be easily the wire exchanges are much easier, or the balloon exchanges are much easier, but they don't have that support or pushability as is seen with over the wire balloons. So there are long balloons available with lengths ranging from 60-80 millimeter to up to 220 millimeter balloons. So advantage with using a long balloon is that we are less likely to miss areas of obstruction, while if we are using a small balloon, we are likely to miss few areas of obstruction. So that is not the case with long balloons. Plus stacking of dissections is also much better with use of a long balloon, and tapered balloons can also be useful because the vessels taper as we go down. So these tapered balloons can be used in those scenarios. So balloon undersizing should be avoided. In case of doubt about the size of vessel, one can use intravascular ultrasound to determine the precise size and use good size balloons so that we get a good result. Small or undersized balloons are associated with higher risk of failure, that is early closure of the vessel, and we should properly size the balloons according to the vessels. So most of the time the anterior tibial and posterior tibial are generally 3 millimeters, 3 to even 4 millimeters in the proximal part, and even distally also they are around 2.5 to 3 millimeter in size. So these size balloons should be used while doing balloon dilatation of tibial arteries. So these are further few examples of BTK interventions. We can see a diffusely diseased anterior tibial and dorsalis pedis artery in the first image, and the posterior tibial is also occluded distally. So the intervention was done on the posterior tibial and lateral plantar arteries with the help of a support catheter, and this was followed by a good revascularization result with good lateral plantar arteries, which is supplying multiple vessels, or the blood supply to the foot is increased after revascularization. This is another example of similar intervention on the posterior tibial artery and the lateral plantar artery. So stents are not routinely used in BTK interventions. They are used only if there are several floor limiting dissections, or one is not able to get a good angiographic result and flow with balloon. And bare metal stents can be used, but they are not preferred because the long term patency is not great, and these vessels are much smaller as compared to the superficial femoral or iliac vessels. So bare metal stents are only used if there are no other alternative options. So drug-eluting stents generally have much better patency than PT alone, but the problem with them is that the longest device available is only 38 millimeter, and the occlusions in lower limb are generally long, say like 100 millimeter or even longer. So one may require multiple stents. So the cost is a limiting factor. So what is done is generally the areas which have flow limiting dissections, they can be stented with a DES, and the rest or remaining areas can just be left after doing a balloon dilatation. So if we look at the early failures of BTK, the PTA is associated with slightly higher failure rates as compared to stents and atherectomy. But if we look at the major unplanned amputation or mortality through 30 days, they are more or less similar with either PT alone or use of drug-eluting stents. So preferably one should do a PTA with balloon followed by a drug-eluting balloon. That is currently the preferred choice in BTK disease, and if there are flow limiting dissections, then they should be addressed with a drug-eluting stent. Another important adjunctive device is the debulking devices. These include atherectomy devices like the Diamond Bag 360, which is the orbital atherectomy, or Mini Hawk or Rock Hawk device. And then there is Jetstream device, or lasers have also been used in below-knee disease. So these devices are mainly facilitators to get you a good result with ballooning and subsequent stenting if required. So these are few examples where these enabling devices have been used with good effect. So this is an extremely calcified distal popliteal artery and anterior tibial and posterior tibial. As can be seen on the image on right hand side, the calcification is very heavy. So this was managed with a pathway device with multiple runs of that device for debulking, and this is the result after debulking. This was balloon dilated, and finally we got a good end result with good reconstruction of the bifurcation of tibial and tibioperoneal trunk. So what are the complications of BTK interventions? Complications associated are generally bleeding or perforation of the tibial vessels, which can be managed with either internal or external compression. There can be flow limiting dissections or distal embolization with distal no reflow, which can lead to worsening of critical limb ischemia, or in rare cases need for amputation also. And if perforations are not detected, they can lead to compartment syndrome in lower limb, and ultimately the most feared complications like limb loss or death can also occur. So one should be very careful in these procedures, and complications should be avoided to the extent possible. So what is the evidence regarding endovascular intervention for CLI? The best or the largest evidence was from the BEST CLI trial. It was a randomized controlled trial published in the New England Journal of Medicine. So it compared surgery with endovascular treatment for CLI in almost 1800 patients. Almost all these patients had infrainguinal disease. The primary outcome of the trial was a major limb event, which included amputation or death from any cause. The median follow-up was around 2.7 years. And the primary outcome occurred in 42.6% patients in the surgical group versus 57% patients in the endovascular group. So it was much better, or the primary outcome was much lower in the surgical group as compared to endovascular group. However, the surgical group was further divided into two cohorts. One where there was a suitable saphenous venous conduit, and the others which didn't have a suitable saphenous venous conduit. So those with saphenous venous conduit, they had much better outcomes, while those who didn't have a good saphenous conduit, their outcomes were similar to the endovascular group. So they concluded that if there is a good saphenous venous conduit and the patient has a good distal target, one can go ahead with surgery if the surgeon is experienced enough in such cases, and surgery provides more durable results. But in patients who are not suitable surgical candidate, endovascular therapy too provides acceptable alternatives. We should also note that these are high risk patients, and event rates at 3 years are very high irrespective of the treatment offered. So to conclude, I would like to say that in absence of suitable targets or saphenous venous conduits, EndoFirst is the strategy of choice for BTK revascularization. Most of the time these patients are high risk for surgery because of their comorbidities. So endovascular first should be considered in patients who are poor surgical candidates, and a good toolbox which should include various sheaths, catheters, support catheters, wires, balloons and stents if required. They are critical to both acute success and improved clinical outcome. And the devices for endovascular treatment of CLI are improving day by day, and we can hope that our outcomes will be better in coming times, and thorough familiarity with their performance characteristics is necessary for their proper use. Thank you for your attention.